Thank you. I'll be presenting the results of NSABP B39 RTOG 0413 on behalf of the NRG Oncology Group. I don't have the disclosure slide, but I don't have any relevant financial disclosures. Just as a little bit of a background, standard breast-conserving therapy consists of lumpectomy plus about 5 to 7 weeks of whole breast irradiation. That was the standard for the past 50 years or so. In an effort to improve the quality of life of our patients, we studied whether or not we could reduce the overall treatment time significantly in these patients down to a week or less by doing a technique referred to as partial breast irradiation, meaning limiting the radiation only to the lumpectomy cavity region and accelerating the treatment down to 5 treatments or less, 5 days or less. So that's how this protocol was developed. We randomized, I don't have the number here, but 4,216 women to either whole breast irradiation, the standard of care at that time, 5 to 6 weeks of radiation therapy, or partial breast irradiation using one of 3 techniques that were in use at that time and still are in use today, meaning either 3D conformal external beam radiation therapy completed in 5 days, or interstitial brachytherapy, again completed in 5 days, or device-based brachytherapy. This was a diverse group of patients, as you'll see in a moment, but we randomized these patients based upon their disease stage, stratified these patients based upon their disease stage, their menopausal status, their hormone receptor status, and their intention to receive chemotherapy. The endpoints of the study, of course, the primary endpoint was to determine whether or not partial breast irradiation controlled the tumor in the breast. In other words, the ipsilateral breast tumor recurrence rate was the same as whole breast irradiation, but the secondary endpoints were also distant disease-free interval, recurrence-free interval, which I'll define in a moment, and overall survival. Getting directly into the results of the study, this was equivalence tests per protocol-defined margin. For us to declare that partial breast irradiation and whole breast irradiation were equivalent regarding the ipsilateral breast tumor recurrence risk, the 90% confidence interval for the observed hazard ratio had to lie entirely between 0.667 and 1.5. I'll show you that diagram in a moment. So we observed 161 recurrences, ipsilateral breast tumor recurrences, as first events. There were 90 in the partial breast irradiation arm and 71 in the whole breast irradiation arm. The hazard ratio was 1.22 and the confidence interval was 0.94 to 1.58. Partial breast irradiation did not meet the criteria for equivalence to whole breast irradiation based upon the upper limit of the hazard ratio confidence interval. We wanted to lie between 0.667 and 1.5. However, the absolute difference in the 10-year cumulative incidence of IBTR between partial and whole breast irradiation was 0.7%. So this slide just shows for you diagrams for you the upper limit of the confidence interval. We wanted it to be 1.5 and it was 1.58. This is the 10-year cumulative incidence of ipsilateral breast tumor recurrence between partial breast irradiation patients and whole breast irradiation. The absolute difference was 0.7%. As a secondary endpoint, we also looked at the recurrence-free interval, which was defined as the time from randomization to the development of first event, either a local, regional, or distant recurrence, regardless of any intervening contralateral or second breast cancer. At 10 years, the recurrence-free interval for whole breast irradiation patients was 93.4%, and for partial breast irradiation was 91.8%. A difference of 1.6%, but this was statistically significant. We did not see any statistically significant differences, however, in distant disease-free interval, in overall survival, and in disease-free survival. So basically, the intent to treat and as treated analysis could not refute the hypothesis that PBI is inferior and could not declare that whole breast irradiation and partial breast irradiation were equivalent in controlling local and breast tumor recurrence. However, as I pointed out, the absolute difference between the techniques at 10 years was 0.7%. The risk of a relapse-free interval was statistically significantly higher, again, for partial breast compared to whole breast. But again, this difference, the absolute difference at 10 years, was also small, 1.6%. Interesting, the breast cancer event rates at a median follow-up of 10.2 years in this population were overall very good and quite low. The IBTR rate was about 4 to 5%, as you've seen. The distant metastasis rate was around 3%, and the overall breast cancer death rate was about 2%. As I mentioned earlier, the distant disease-free interval, overall survival, and disease-free survival were not statistically significant between the two arms of the study. I didn't show the data, but grade 3 to 5 toxicities were low, as well as the rate of second cancers, and they were not different between the two arms. We are performing additional analyses currently to evaluate the secondary endpoints, of course, of quality of life and cosmesis. Because the differences relative to both ipsilateral breast tumor recurrence and relapse-free interval were very small, PBI may be an acceptable alternative to whole breast irradiation for a proportion of women who are undergoing breast-conserving surgery. Thank you.